my pleasure to introduce Corbin Griffen, one of our industry partners. Very important, metabolic health. So Corbin works from in a company called Dexcom. Some of you may have heard of Dexcom. Well, you're going to talk about it. So let me get your slides on, then you can introduce yourself.
Yeah, I'm a clinical scientist for Dexcom. So we are a global organisation who manufacture continuous glucose monitors, predominantly for people living with diabetes. We also use glucose biosensors. They're not currently in the UK or Europe, but in the US at the moment. We're a global organisation with our headquarters in San Diego in the US, but we distribute our sensors across Europe, the Middle East, Africa, Asia, the US, North America, South America. So my role is involved with any kind of clinical evidence generation that we conduct in either Europe, Middle East, or Africa. I'm actually flying to Saudi Arabia straight after, so we've got some exciting projects going there as well. So it's really going well. And I'm going to my talk is on kind of the role of CGM and glucose monitoring we're focused on older adults.
There we go. Perfect. I'll hand over to you just.
To just explain how CGM works. So it's a kind of a sensor the size of a £2 coin, if you like, which is inserted into the skin. So we are indicated to have this from an anatomical standpoint, either the back of the upper arm, the abdomen, and for children, the upper buttocks. So I'm a type 1 diabetic myself. I wear a sensor here on my arm. It's a small filament that lies under the skin, and it continuously measures your glucose in your interstitial space, so the fluids beneath your skin. That's then transferred into an estimated blood glucose value via an algorithm. And that value is continuously displayed on some kind of receiver. So it could be a smartphone or receiver device. And every 5 minutes, the user can see what their current glucose value is. So that's a summary of what our device does. Okay. So just to set the scene, really. So we know that diabetes is a global crisis that remains uncontrolled. So you can see from the left-hand side of the slides, kind of the annual cost of diabetes is rapidly increasing. So from around $151 million in the year 2000, and it's projected to hit $783 million by 2045. Oh, it's not on the screen, is it?
Otherwise, it's blocking your.
Oh, yeah. So globally to healthcare systems worldwide, it really is an economic burden. And there's some data to suggest that people who are living with diabetes have around 2.6 times higher expense than those who are living without diabetes. And even more strikingly, in the US, more than 1 in 4 US dollars are spent on people on diabetes alone. Now, for type 1 to type 2 diabetes, the current standard of care is to use a finger stick sample to draw some blood and use a glucometer to measure their blood glucose values. However, this really doesn't tell you the whole picture. So most people with type 2 diabetes may finger stick maybe once, twice, 3 times per day, and that only gives you a snapshot of what your current glucose level is. So most people with type 2 diabetes probably finger stick in the morning to get a fasting level, potentially before or after dinner, and at tea time. But that doesn't really tell you about anything regarding their glucose variability during the day. So it's really difficult for the user themselves, or indeed healthcare professionals, to adjust therapy based on self-monitoring of blood glucose. Now, over the last 5 years, continuous glucose monitoring is becoming the standard of care, certainly in type 1. So most internationally recognized guidelines, such as the American Diabetes Association, called the ADA, or the European Society of Diabetes. There's also an Asia-Pacific consensus panel as well, who recommends CGM, certainly in all type 1s, and in insulin-treated type 2s as well. And that's going further, actually, next year into gestational diabetes, and even with people with type 2 diabetes who are maybe on oral medications or injectables, such as GLP-1s. And what continuous glucose monitoring offers, which is far superior to blood glucose monitoring, is that 24-hour continuous data. So you can see from the slide here, on the dot there is where that finger stick sample was taken previously, but that didn't give any information on what happened overnight. As you can see on the left-hand side there was peaks. This is in milligrams per deciliter. So that's around 15, 16 millimoles per liter. That reading was high overnight, kind of settled in the daytime, and then rose after the meal and again at tea time. But current standard of care would not give you that kind of data for either the user or clinician. And that's where CGM really is superior to SMBG. When we're talking specifically about older adults, glucose control, glycemic control, really depends on the frailty status of the individual. So for fit older adults, and for most people with type 2 diabetes or type 1, the HbA1c target, so your average glucose roughly over a 3-month period, is around 58 millimoles per mole in UK money, or 7.5% as an A1C. As you kind of progress along the frailty scale, the overall glycemic target kind of relaxes. As we get older, the most important aspect is to reduce hypoglycemia. We know that's associated with increased risk of falls, and we know as you get older, your bones become more brittle, you may be sarcopenic, so you might be, so we want to avoid long-term hospital stay. As we know, I did my PhD in sarcopenia. You stay in hospital for 5 days, your muscle mass reduces significantly. So in older adults, the value of CGM really is in reducing hypoglycemia. And most CGM devices, including ours, have certain alerts that helps the user to understand where their glucose is going. So, for example, our Dexcom devices has alerts such as predictive low soon and going low. So it actually alerts the user before they get to that hypoglycemia stage that they're heading towards that direction, and that hypoglycemic event can be avoided. Now, the benefits of real-time CGM. So when we talk about real-time CGM, there are 2 types of CGM. There's something called intermittently scanned. That's no longer really available in the UK. There is in some places globally. That's where the user has to physically scan the sensor to get a reading. Our device is real time, so it's continuously via Bluetooth projecting that signal and that value to the person's receiver or feedback. But there's plenty of randomized control trials, real-world data, registry-based studies, and retrospective kind of claims analyses that have looked at the effects of CGM on people with diabetes, particularly in older adults. They've shown clinically meaningful reductions in HbA1c. So in the diabetes world, the clinically relevant reduction is typically a 0.5% reduction in their hemoglobin A1c. They've also shown improvements in glycemic targets, particularly what we call a time in glucose target range. So for any person with diabetes, the international recommended target range is between 3.9 and 10 millimoles per liter. And as a target, the user should target 70% in this time range, and that correlates roughly to a HbA1c of 7%. And every 5% improvement in time in range in between 3.9 and 10 is clinically meaningful for reductions in diabetes-related complications such as retinopathy, neuropathy as well, and other complications. As I mentioned, hypoglycemia is one of the biggest risk factors in older adults with diabetes. So CGM has been shown to reduce hypoglycemia, both from measured on the CGM, but also severe hypoglycemia, so those that require third-party assistance or hospitalization. And then lastly, as we talked about today, improve quality of life and reduce complications. So there's some evidence to show that using CGM makes older adults more confident to do activities of daily living, more confident in using their insulin, and reducing those long-term risks as well. So just to dive a bit more into that evidence, so these are 3 randomized controlled trials that we've conducted over the last 8 years or so, and they've shown that real-time CGM can improve clinical outcomes. There's also been high usage. So importantly, of any medical technology, if you don't use it, you're not going to get the benefit. For CGM, there's really need to be using it 70 to 80% or more. And we've shown that in our clinical studies. So on the left-hand side, we conducted a study called the Diamond study. So this was a study in both people with type 1 diabetes and type 2 diabetes who injected multiple times per day. So they are on something called a basal bolus regimen. So they had a basal or a slow-acting insulin either once or twice daily, and they had rapid-acting insulin every time they consumed food or meals. And in this study, so this was a post hoc analysis just in the 60-plus age category, there's a 0.9% significant reduction in HbA1c and a 0.4% greater effect compared to the standard of care, which was self-monitoring of blood glucose. So just short of that clinically meaningful difference. And the CGM measured hypoglycemia, which we call it something called time above range, which is greater than 13.9 millimoles per litre, and glycemic variability. So we measure that normally by coefficient variation or standard deviation of the glucose, significantly decreased greater than blood glucose. So overall, there was a reduction in average glucose control, and that was really generated by a reduction in hyperglycemia. On the middle of the slide is another study we've conducted called the Mobile study. So this was a study conducted in the US in the primary care setting in people living with type 2 diabetes who are only using basal insulin, so there's the slow, long-acting insulin, once or twice daily. And from baseline, whilst using CGM, their HbA1c decreased by 1.1%, a 0.4% greater reduction than blood glucose monitoring. The reason we didn't see greater, the actual control group received way more standard of care than they would normally. So the control group actually improved quite significantly as well, but it's still a meaningful reduction between groups. And we saw nearly a 20% increase in time in range, which I mentioned a minute ago. 5% is clinically meaningful. So a 20% is a significant improvement in that time in glucose range, and a 12% greater decrease in hyperglycemia. And then last on the right-hand side is the Diamond study again. That's just in the type 2 population, and there's similar results to the type 1 and type 2 pooled cohort. So there's a significant reduction in hypoglycemia, which is clinically relevant, and a 0.4% reduction in HbA1c. And in all our studies, we measure satisfaction rates and also CGM usage. So in the Mobile study, for example, usage was around 7 at 10 days minimum usage, and that's been correlated in kind of larger studies to improved outcomes. And then the next paper is actually hot off the press. So this was only published last Thursday, I believe. So this is a study published in BMJ Diabetes Open Research and Care. So myself as one of the authors, we collaborated with some world-leading endocrinologists, Dr. Roy Beck, Dr. Richard Bergenstall, and Dr. Thomas Martins to publish this. So this is a post hoc analysis of the mobile study again that I just presented, but this was the time point at 3 months. So there's a real gap in the literature to understand how quickly, if you put CGM on someone, how quickly does their glycemic control actually improve? And that was what we tested in this post hoc analysis. So this was 175 adults. So it was a 2-to-1 randomization. So 116 in the CGM group and 59 in the control group. And as you can see from the figure there, from baseline, their time in range was 41%. Within the first 7 days of putting a sensor on individuals, their time in range nearly increased by 10%. So double the clinically relevant improvement. And after 3 months, that increased again to 22%. And when we looked at the HbA1c between the CGM and the control group, there's a 0.6% reduction between groups in favor of the CGM group.
Using GMI?
No, A1C. Yeah, so the mobile side looked at baseline, 3 months, 8 months for HbA1c. But this analysis, which is really hot off the press, really does show that the biofeedback that you get from the device, so that's kind of learning what happens when you exercise or when you consume foods, is rapidly absorbed by people, and you learn very quickly changes, or people tend to adapt their lifestyle quickly. We didn't actually see any changes in their therapy regimen in this analysis post hoc, which suggests the majority of these changes are behavioral. We did measure patient-reported outcomes. We didn't see anything, but it was the clinic, the effect size to see it's so small to detect it. You need a huge sample size really for some of these PROs in diabetes, and that was a secondary outcome. But the data does suggest there's behavioral changes occurring somewhere. So just to summarize, the diabetes diagnosis and cost is continuously rising. There's some robust data now from randomized control trials, meta-analyses. There's also some data now in, as I mentioned, people without using insulin, and also people's on the pre-diabetes spectrum, that real-time CGM provides dynamic information, which the user can use, and the speed and direction of where your glucose is going. So we can measure the rate of change from our device to really understand where your glucose is going to be in 30 minutes' time. For older adults with diabetes, the key really is to minimize hypoglycemia, to reduce the risk of mild cognitive impairment, risk of falls, and hospitalization, whilst maintaining kind of glycemic control with their physical status. And as I mentioned, there's some really good clinical evidence now on the benefits of real-time CGM in older adults, and that will continue to expand, I'm sure. Thank you for listening, and happy to answer any questions.
Thank you so much, Corbin. Fascinating. And just going back to Angus's point about the economic burden of aging societies, it's about pre-diabetes and type 2 diabetes. As we have bigger proportion of individuals in that space, that's billions to the health system.
And that's where the evidence is going now.
Yeah.
There's some pretty robust evidence now in people living with diabetes. Yeah. Now it's looking at pre-diabetes. We have a registry in the US that's ongoing, looking at pre-diabetes, and it's a longitudinal, so up to about 2 or 3 years now. The trouble with a lot of this evidence, it's long term. It takes a long time to get it.
And there's preventing going from pre to through the spectrum to type 2. Yeah. So it's really important to embrace these technologies and integrate it with other technologies that you're developing. And also, you're talking about small data sets. Well, China has a big data set, so maybe you can work with a Chinese partner. I mean,
We're expanding our evidence, yeah. So
integrating with our collaborations with the Chinese, using your technologies, because we're doing LT, cognitive decline, and so on, in relation to metabolic and inflammation. So now, at the moment, I know you don't do the consumer level in the UK. But
we don't
in the
yet.
US, it's a big, it's a big boom at the moment. It's a fashion accessory to wear a white patch. Just people put a white patch without connecting it. But so I don't know the uptake of CGM in China. People using CGM.
we are
Do you
active.
have Chinese?
We do. And we have an office there as well. Where's the APAC office? Is he?
Dubai.
Never met the Dubai people, by the way. Can you go?
So we got a team. We've got a medical affairs team based. Got a gentleman based in Japan. So we are active there.
So maybe Gene's not here, but we can ask through the British Embassy how we can connect to the Chinese ecosystem. Yeah, sorry, yeah.
How long?
How long?
How long? Good question.
Good question. How long?
So our device is.
Look at
Can hear?
Yeah, sure, yeah. So our device is. So we have FDA and CE marking.
Yeah.
Yeah. But for 10, so we have a 10-day sensor wear period with a 12-hour grace period. So 10.5 days per sensor. After that, you take it off and then insert another sensor. And it's a really quick warm up. So only 30 minutes is needed, and then it starts giving you data.
So what's the cost like in marketing compared to what someone's already spending on insulin injections? Is this the same again, or obviously there are big benefits for long-term health and cost, but kind of day-to-day cost?
Yeah, I mean, we've done quite a lot of health economic analyses. Of course, the price of the sensor is above what standard of care is. But when you look at that over a long-term course of so we typically apply a 50-year life horizon in our economic analysis. So the cost offset is reduced in pretty much all the health economic. It's mostly reduction in acute diabetes events. So there's an investment, of course, from the health or the payer for the device, but then that loss is offset through hospitalization. Yeah.
Yeah, they use this in China.
They do, yeah.
But does Dexcom operate in China?
We do.
Okay.
那比国内的先进吗？
他们也在卖，国内也卖。
对，中国有没有？
I'm just telling you have in China a market.
Yes.
Any other questions? Any online questions? Anyone online has a question? If not, we should let you go because you need to leave
I
it
do, yes.
and say hi to your Dubai team.
Thank you.
I'm going to be out there in February.
Okay.
Yeah, there's what's it called? The health thing, WHX,
Okay.
which is Dubai Health. Whatever it's called. I'm sure Dexcom will be there.
We're at ACE.
Anyway, great. Well, thank you very much.
Great, no problem. Thank
Great
you.
call.